I'm Agata Krasny-Pacini from Strasbourg University, and I'm going to talk to you about single-case experimental designs. SCEDs are a group of methodologies testing the effectiveness of an intervention at a single participant level. This paper will give you many reasons to consider SCED as your research method and as a clinical evidence-based practice. SCEDs are especially useful if you work with low prevalence conditions or with challenging family needs or atypical situations or fields lacking any guidelines for interventions. For example, if you are interested in showing that your intervention allows to achieve personal goals, you could use a randomized multiple baseline across different child's goals. Different SCED designs exist, but their principle is essentially the same. You study prospectively and intensively a single person or a small group of persons. You measure repeatedly and frequently the outcome in all phases of the study, and you apply sequentially intervention at randomized time points. Or you can introduce and withdraw an intervention in a randomized order. SCEDs can also be extremely powerful on the front end and back end of RCTs. On the front end, you can modify and optimize your intervention on a small scale before using excessive resources. On the back end, you can optimize interventions and experiment interventions in participants who do not match the often very strict inclusion criteria used in RCTs. In fact, we all face the challenges of discouraged, tired, fed-up children and families, challenging parenting styles, intervention for those difficult to reach and difficult to motivate families are desperately needed, but the loss to follow up discourages researchers from including this population in RCTs. Whereas in SCEDs, it is not such a problem, because repeated measures give you data even if the family withdraws from the trial prematurely. And also, the intervention can be adapted so the family does not withdraw from the trial. And how you adapted the intervention for that particular family is valuable data that will enhance the translation of knowledge from research to the clinical setting. Even if you work with a population where many RCTs and meta-analyses have shown that an intervention is effective, each one of your patients could be an atypical responder to that intervention. So in clinical practice, you could use SCEDs, for example, to decide what to do for that particular patient. Methylphenidate is supposed to be effective for my child with ADHD? Okay, let's test it rigorously before giving it on the long run using an N-of-1 trial. You think this orthosis does not help your child? Okay, let's test it on multiple comparison with and without the orthosis using an alternating treatment design. This paper covers main SCED designs and when each design can be used. You will learn why, whenever possible, aggregated N-of-1 trials should be preferred to RCTs and why the Oxford Center for Evidence-Based Medicine now categorizes N-of-1 trials as level 1 evidence. You will learn how SCEDs promote flexible research and at the same time, how to build a strong and valid methodology using SCED, which design to use, how to calculate power, which randomization to use, and what constitutes a valid and reliable baseline for comparison. Sometimes we can learn more by in-depth study of a single participant than from a big RCT that may give us the reassuring illusion that one size fits all. So let's focus on one particular child to better decide what is effective for her and at the same time to gain knowledge for child neurological research.